Okay, thank you. Okie dokie. Ow. I didn't chew enough before I swallowed. Okay. Spinal cord injury. I feel like I have chicken in my teeth. All right, so in your book it's going to be dermatones and myotones and reflexes, okay, which is on page 226 and 227. Okay. Chances are, so the ones that we went over last week, like C4, C5, C6, C7, and C8, and are going to be the ones that you are going to be most concerned about for cervical. Remember we discussed that like in the thoracic area, there's just way too many, Brain is going dead. But there is way too many like muscles that are innervated by the same area that, and they're too, it's hard to distinguish one from the other. Okay, to absolutely say, all right, you're going to see this with extension, you're going to see this with, because you're not. Okay. So you know that when you get into the T's, that you have to worry more about are they going to be able to keep their trunk up? So we're talking postural control. The lower down, the better it is, right? As far as spinal cords go. And so if they have a T1 and then they have a T10, what are you going to see difference-wise? Yeah. Yeah, a lot more postural control at a T10 than there is going to be at a T1. Okay. All right. And then L1 through S1, S2, except for what is crucial about S4? It is. What distinguishes movement wise if there is still, yes, the anal wink? No, you thought it was 5? There is no 5. No, there is no.
It's S4/5.
Yeah. So that is where you're gonna know whether it is complete or incomplete.
So if I would have checked that one patient for an anal wink, I would have been able to tell you if he was complete or incomplete.
Which patient was it?
The one that was walking.
That'll tell you right then.
I mean, he's walking. I still should have asked him if I could check his anal. He probably would let me. That would have been your license.
Yeah.
That would have been.
Unless you were filling out the Asia scale. Remember? Yeah. Unless you're filling out the Asia scale, you're not going to be that worried about it. All right. So we know that. What is this? What level is this? Yep. 5 is biceps, correct.
6 is tenodesis. 7 is triceps.
Yes. So 6 is tenodesis, but why is 6 tenodesis? Wrist extensors. So if I just relax my hands, okay, I flex them, they're like this, I extend them, what happens? Passive insufficiency that I have finger flexion, okay? So that allows me to come in here and do this, correct?
Very good.
Mhm. That allows me to go ahead and grab a hold of things, right? I extend, I can hook, I can pull because I have biceps, right? I can't push. Why can't I push? I don't have any triceps. So where do triceps end up with? C7. And you also get your wrist flexors. C8. What's more important about that? Finger flexors. Yep, your finger flexors are good. So now I don't really need tenodesis because I can flex my fingers. Get it?
Got it.
Good. Okay. So L2, what does L2 do?
Hip flexion.
Yep. Because it's got the psoas. Psoas is one of the major flexors, right? Okay. So better move this to the side. L2, what's L3? Knee extensors, because it's your quadricep muscles. What's L4? Dorsiflexion, because it's tibia anterior. Okay. Also, extensor hallucis, so you can extend your big toe. What's L5?
That one's the long term.
The big toe. Sorry. S1, plantar flexors and your hamstrings, right? So you get the rest of them in there. So the more that you have, obviously we know, the more that you can control. Okay, so let's go look at your chart real quick. Okay. So we know that there's some important ones, and which ones are those important ones in the cervical area? Yeah, C4 through 8, but which one gives us tenodesis? C6, because it's wrist extensors, right? Okay. And then C7, right? Because of triceps. You don't have to do that tripod thingy anymore, right? Because they can actually have their triceps there. I mean, C5, you've got your biceps, so that really does help a lot, okay? And then C8 is your finger flexors, right? So we don't need the tenodesis grip anymore. Okay. All right, so we get to which one would be the most important one that we start off with in the lumbar area?
Two. The hip flexion.
Most important,
Knee extension.
L3, right?
Oh.
Huh? What'd you say? Oh, yeah, because of knee extension. Why is that important for walking? Okay. So you have your knee extensors, and that is really your most important one. And then you have L4, which is your dorsiflexors. So you're going to get rid of your foot drop, right? And then L5 is for toe off, correct?
Yeah.
Great toe extensor. Okay. So functionally, when I think about these, even though you have all those levels, those would be the ones that I would concentrate on. You should know them all, but functionally, aren't these the ones that you really, really need? Like they make major improvements to your quality of life. Okay. So you already went through the reflexes with Deanna. Okay. Bicep reflex. Okay. Brachioradialis reflex. Okay. You went through the knee jerk or your patellar reflex. And then you also went through your Achilles reflex. Okay. And the tricep reflex. So I don't really want to go through those again. Okay. In the essence of time. So muscles affected, we already kind of talked about that. Elbow extensors or elbow flexors. okay, which is going to be your biceps, okay, and your wrist extensors, which are what muscles? Yep, and longus. Yep. Yeah. So they're not going to go in through all that. They'll probably, with spinal cord injury, talk to you more about what the muscle groups are. Correct, guys? When they talk about spinal cord injury on the exam, do they make you be specific with muscles?
No,
Okay.
not usually.
Okay.
They're gonna ask you to treat.
Yes.
Or like what kind of wheelchair. One that they definitely like though is knowing the difference between your L4 and your L5.
No, I would have said the C's. Like
Well, definitely those two, but for the lower extremity, because that's something that I've struggled with.
Okay.
Orthosis or orthotics for those.
What'd you say?
For the lower extremities, they're going to ask about the kind of orthotics you need for them.
Right. We're going to talk about that.
We're going to talk about the wheelchair.
But sometimes
Okay.
it'll be like if you're testing the dermatomes and you're touching a specific part of the lower extremity, like what area is it going to be?
Okay.
What level is it?
Okay. Yeah. So that's why you need to make sure you study that dermatome thing. Okay. Make sure you go through all of the dermatomes with that. Okay. What was the page? Was it 272? Let's go to that because I absolutely love the way that they do that in here, that they go through all your functional skills assessment with it. Okay. So if you're a C5, are you a high tetra, mid tetra, low tetra, or a para? You're a high tetra, okay? If you're complete, okay? So when you look at this, your bed mobility, remember we did these when we were in class, okay? We had to really teach them how to roll. We had to teach them how to sit up, swinging their arms back, right? What kind of wheelchair are they going to use? They're a 5. They have biceps.
So C1 through C5 are considered high tetra?
Yeah, oh yeah, yes.
So they can use a push pincher. Their bicep.
They have no triceps, so all they'll be able to do is,
Mechanical.
yeah. They might be able to use like a stick. They have biceps, so they can kind of, they have shoulders too. So they have their shoulders, so they can work it from their shoulders. So they're going to need a joystick.
Did she say like a goalpost?
Like a goal post, because they don't have finger flexors. Yeah. Yeah. So they're going to have to be able to like move it around with their shoulder is how they're going to be able to use the wheelchair. So it's going to have to be oh my God, I'm thinking manual and electronic. It's going to have to be a motorized wheelchair. Okay. Might they need stuff for trunk control? Mm-hmm. How about their head? Do they need head control? No.
Yes. JK.
They have head control going on, but they might need stuff like to keep them from falling forward in the chair because they don't have any trunk control at this point at all. Okay. So maybe like a harness to strap them in to hold them up. Okay. They're going to need to be doing positioning. What kind of positioning are they going to be able to do? How are they going to position themselves and how are they going to give themselves pressure relief? Side to side. Yep. They could also do posterior, right? Because they just lean forward. Yep, just leaning forward. Okay. But are they going to be able to push up? No. So how long do they do positioning for? Pressure relief. Thank you. 2 minutes. And how often?
Every 30.
You got that? Every 30 minutes. Remember that? Pulling it out of your little brain cells there?
Little prince.
Well, I didn't mean it that way. Well, they are little. They're microscopic. I didn't say anything about how many you had. It's they are. You can't see them.
That's a good save.
It was a good save, wasn't it? You can't see them unless they're under a microscope, so they're little and tiny. But I didn't say that you only had like a tiny amount of them, right? Wow, that was a really good save. All right. So what kind of assistance are they going to need? A lot of assistance. A lot of assistance for bed mobility. What kind of assistance are they going to need for transfers? Yeah, they're going to be dependent to transfer from like the chair to the bed. What might they need? A sliding board. Yes. So that's going to make it even more important that they're doing that pressure relief because they end up with that sacral ulcer. But then you also have to worry about skin shear, right? So you want them to bump them, try to, they're not going to be able to bump. They're going to need help because they can't use their triceps to bump themselves along to get over somewhere, correct? So they're going to be doing a lot of skin shear. Okay, so we talked about weight shearing and pressure relief. What else might be beneficial for them to have in their wheelchair?
Yeah.
What kind of cushion?
Donut.
The Roho cushion. Yeah, a Roho cushion, an air cushion, something that is not going to make it hard on their sacrum. Yeah, not a standard old foam cushion. That's probably going to be a problem. Okay. They are very expensive. Yeah. The other factor about it is too, are these people going to be continent or incontinent? Bowel and bladder or just one or the other? Yeah, both. So how does that relate to skin health? Yeah. Not very good. Not very good skin health. So you need somebody who's going to be helping them a lot. Okay. All right. So we talked about weight shifting. What else would be helpful in the wheelchair for them? We already know that they're doing an electronic wheelchair. So what other feature might be helpful with the pressure relief? Tilt in space. Very good. Yep. Yeah, very, very good. Tilt in space. Yep. Yeah, and we know that having them use the electronic wheelchair because they've got it. How are they going to lock brakes? How are they going to do any of that stuff that you would have to do on a manual? How are they going to move they're not going to be able to do that kind of stuff. So they're going to need help.
Would a tilted space count for the pressure relief?
It does. Yep, it does count for it. Yes. They're not going to ask you that question, but that's part of the reason they come up with a tilt in space is because it does help with pressure relief.
What's the wheelchair for people use for orthopedic hypertension?
A tilt in space?
Is that what they use?
Yeah, because you could do the same kind of thing, but we also talked about a tilt table. Remember? You put them on a tilt table so that you can slowly start bringing them up. And remember, there is a procedure for that. You want to look to see if you bring them up every 5 degrees, see if their blood pressure drops. Okay. And then if it doesn't, you can bring them up more. But then as soon as it does, you want to lower them back down again. Okay. By 5 degrees. The tilt tables? Yeah. Where did you have one at?
I don't know. I think it's like a family friend.
That's kind of interesting. Are these people going to be able to walk? No. Walking is done. Done. Okay? Not going to be any walking going on there. So they're going to need a lot of assistance. Assistance with feeding. The C5, they've got biceps, but they don't have the tendinosus grip. So trying to feed, like maybe if you gave me a straw, if I had a straw, I could drink this because I can't bring it to my mouth, right? So if I had a straw, that would work. But how am I going to get any solid food in? But maybe you probably need a caregiver. Yeah. Or a feeding tube, whatever ends up happening to be. Okay. So now we can become a C6. Okay. We have wrist extensors. We get to tendinosis grip. All right. Bed mobility. So what does our assistance go down to in bed mobility? Yeah, it's more of a min assist. Yes. And then as you get to triceps, they can do it independently. And when you actually end up getting into like that, it's just lower extremity, you're definitely going to be all independent if it's a paraplegic. Okay. Transfers. What does that look like? They're probably still going to need a sliding board, but not as much assistance. No.
Because I know they can use it for slide boards, for floor transfers and all.
What are you doing?
Yeah,
getting in and out of the car, they're going to need it. Getting on and off the floor, they're going to need it. That kind of stuff, they're definitely going to need it. Okay. But if they're just transferring to like the bed or the commode or a shower chair, they can probably do that. They can roll in on a shower and transfer over to a shower chair and do that. Okay. Weight shifting. Are they going to be good with weight shifting? Much better. Yeah. Because they've got biceps, right? Hook their arm through, hold themselves. They can probably get better posterior because they're not just relying on gravity. They can use their triceps for that or their biceps, and they have the tendinosis grip so they can grab onto stuff. Okay. Wheelchair management. Do you think that they're still going to need a manual wheelchair or, electronic wheelchair? Yeah. Yeah. They probably should use it. Especially if they're going to go maybe for short distances around the house, they could use a manual, but because it might be more, it's going to be very tiresome. Yep. Very tiresome. Electronic. Motorized wheelchair because I keep not being able to figure out. Yeah, it's going to be dependent. Remember, choosing what's in the question. Don't assume anything. Just go ahead and look at what you think, are the pertinent information. Stick to that and then don't assume stuff. Don't overthink it. Okay. I would definitely say that for community mobility, they definitely need a motorized wheelchair. Definitely. There's no way they're going to be doing ramps, curbs. Yeah, any of that kind of stuff. All right. I've definitely seen when they get to C7, like I've seen people with those really lightweight wheelchairs that are younger that are able to zoom around all over the place and they don't want a motorized wheelchair because and they play sports. Yeah. Basketball. Yeah, they play different sports for it. Okay. Are they going to walk? No. Is a C7 or a C8, is any of the C's going to walk? No.
They might have a really good
They might, like,
They don't have trunk control.
but they got some strong arms.
So they could have strong arms, but they don't have trunk control.
They have a really good
And so they can't do extension. They can't do back extension. Are they going to be able to do a handstand?
Try it.
They could throw themselves up.
I don't think anyone's tried.
Yeah.
Here, I'll go tell you in a bit.
If they throw them, maybe if they're supported by a wall, possibly.
He'd be like, I challenge you to a handstand.
I know. I'm not doing that.
I do it.
I am not doing that. What kind of cushions and that kind of stuff do you think they're going to need? Still, they'll still need the same thing that we talked about. All of those at the C level will. Okay. All right. But do you see how we're figuring all that out? Okay. Stop that. I didn't say they had, did not say they had puny brains. I said tiny brain cells. There's a difference. You're evil. You're totally evil. And so you can figure out most of it by just, if you look at the table, but you can see where all that's coming from. All right. And then when we end up getting into lumbar, of course, they're going to have a lot more mobility. Okay. So if they have knee extension, okay, yeah, let's say they have knee extension, but they don't have dorsiflexors. What can you use to help make them walk? Let's say they're an L4.
What are those? Yeah,
Ophos. Yep. Or what kind of assistive device do you think they'll need? They might be able to use a cane. Do they need an assistive device?
Well, I mean, it depends.
They may not. Yeah, it depends. It depends on their strength of everything else, right? And their balance abilities. If they have poor balance, you may want to put them in a cane or a walker, okay? But and they've got an OPHO, but you see people walking, I see people walking around all the time with OPHOs, bilateral OPHOs, and they're not using a cane.
Were you one of those, Miss Lisa?
No, I wasn't. I was not.
I went on a 2-mile walk, walking like that. Oh, there's so much pain.
I know.
Yeah.
I know.
I don't know why my hips
My biggest problem now is like after I walk and do a lot of walking, especially on uneven terrain, like then my leg gets really tired still. No matter how hard I keep pushing it and trying, it gets really tired. But, yeah, but poor Andrew and Raul saw me the first day. I was, yeah.
You were great for me.
But did I come in better that week? For poor Raul, I was kind of messed up.
You were a lot better because one of our first visits with you did the
Oh yeah,
Wait, how did you work on this?
he was at Willpower where I went for therapy.
I wanted to be there for you. Would have been terrible.
For my
I think
therapy,
you should have visited everybody while they were there.
she would have made fun of me. Oh my god,
And did some therapy with
how
all
many
of us.
emails you have to do.
huh?
What, willpower?
Like if you did a treatment at every of our
Yeah.
If you were an actual patient at all of our.
Talk about continuum of care. That would have just been awesome for like good, consistent care across everybody.
you'd be like, we got problems.
Yeah,
Come on,
definitely.
Lisa, I want to do some manual therapy.
definitely. What about for great toe extension? What would you do? You're going to use anything for any orthotics for great toe extension? Not really. Okay. Yeah. You, huh? Make sure. What'd you say? No, just want to make sure, maybe make sure that they are wearing shoes, I would think. You know, you want to make sure they're wearing shoes. Not listening to you guys. Knee extension. If they have hip flexion, okay, which was what, L2 is hip flexion? Can they walk with L2? Yes. They can walk with L2 with a CAFO. Are they going to need a CAFO with knee extension? But what might they need? Yes. Get it? See why they need an OFO?
Yeah, because they have the extensions of maybe just.
Yeah, but they don't have this. Yeah. They don't have dorsiflexion. So they're going to need that. Okay. This might be a cane with an OFO. Again, single point cane. Okay. This might be what? Mm-hmm.
Oh, the ABD.
What kind of crutches? Yeah, crutches, like loft strand crutches. Okay. They might need those. They might need loft strand crutches here. Okay. Not a cane. They're not going to do well with a cane at all. Yeah, the Forrest Gump crutches. Yeah. And they may start off with a walker. You know, they may start off with a rolling walker first before they, huh? You hate walkers? I hate walkers too. All right. What is the number one complication or precaution that we have to look out for? Okay, if they are a tetraplegic or quadriplegic. Thank you. Autonomic dysreflexia. It was so important that I actually wrote it out for you. Okay? So and it is at what level? T6 and above. Okay? We don't have to worry about it below T6, T7 or below, right? We're good. Okay? What causes it? Yeah, what could be bothering them? Because they're not going to say that your patient has a noxious stimulus. Pinching, something sharp they're sitting on, clothes are too tight. What line? Catheters. Yeah. Catheter, it's either like clipped or folded, or the bag is full, right? Okay. What about if they had a bowel movement? Bag full. Sorry, bag full. What? Okay, so that if their clothes are pinching them, could that do it? What if it's too hot or too cold? Temperature extremes. What if they're hungry? Could be if they're hungry. Okay. Any of those kind of stuff could be causing them. Anything that's enough that it's going to be a obnoxious stimulus. What are the symptoms? Increase in, what'd you say? Increase in heart, increase in blood pressure. Okay. How is that different than orthostatic hypotension? No change in position. Yeah. So with our ortho people, we tend to sit them down, lay them down, orthostatic hypotension. Okay. With our autonomic dysreflexia people, are we going to go ahead and lay them down? No, we're going to sit them back up. Okay. Because their blood pressure goes up.
Yes.
Yeah. Blood pressure goes up and their heart rate goes down. Yes. Okay. What else do they have? What else is a blurred vision? What else? Sweating above, right? And goosebumps below. Remember, that's a biggie. Okay. Yeah, they're flushing. And headaches. Remember, headache was a big one? Okay. Headache was a big one. Okay. So first thing you're going to do, this was a test question on my test. What's the first thing you're going to do? Very quickly. Yes. Yep. And you're going to put them in sitting. Okay. And call 911 if it doesn't resolve right away. Okay. Or you can't find out what the obnoxious stimulus is. You're going to call that before you wait to see if it'll resolve because you haven't found out what the problem is.
Now, if you, let's say it was closed pinching and you found it and you corrected it, would you notice relief, or would it still?
You should notice a relief. If you don't notice a relief, then that wasn't the problem. There must be something
So you
else.
know if you fixed it.
Yes. You should know that if the symptoms start to resolve, you're okay. All right. If they don't resolve, you didn't figure it out. You need to call somebody right away.
You know the time period for that?
There is not a time period. No, it's not like the.
Well, I know it's like an emergency. Like if you start to see it and you can't fix it, for like is there time for kind of what he said if you get better?
To be honest with you, I've never had anybody that has had autonomic dysreflexia on me, but I know one of my really good friends, her daughter is married to a guy who is a quadriplegic. He jumped off of a railroad bridge into the river and broke his neck when he was young, like in high school. And he gets autonomic. I asked her, I'm like, does he get autonomic dysreflexia? And she's like, yeah, he gets autonomic dysreflexia every once in a while. I guess it resolves very quickly. Yeah. They start to feel better pretty fast. Ask them because they can talk, right? So I would go ahead and ask them.
I kind of knew what was going on with the caregiving. He'd start sweating. He'd have a towel. He'd be wiping his face. He was C6. And then he'd say, fix the bag, fix this, fix that. And he'd just keep telling me what to fix.
There you
I'd
go.
just keep fixing until we figured it out.
Yeah, that's a good patient. Well, he's lived this. It's not, remember, your spinal cord injuries usually are not brain dead.
He's been in spinal cord for 20 years.
Yes. So they got the hang of it. They get it down. They do whatever they need to do to function to the best of their ability, and they can verbally tell you stuff. So it's not like, oh my God, I got to search around and look for something and I have no idea what it is. Okay. Unless they have locked in syndrome, and then it's a different story. Yeah, then that's a different story. What other potential complications or precautions are we going to have with people with spinal cord injuries? Do we have to worry about, if they're an upper level spinal cord injury, do we have to worry about contractures? Do we? Not, because they're flaccid. They have flaccidity. They're not a spasticity or anything. There's nothing going on in the muscles down there, right? But what do we have to worry about? We talked about incontinence, didn't we? And positioning. And why are we doing that? Skin breakdown. Yep. Okay. So we talked about using a tilt table, which would probably be early on if they were an early spinal cord injury. And what was the benefits of this tilt table? Weight bearing. Exactly. Weight bearing. Okay. So that we can counteract what pathology? So we want to put them on a tilt table, okay? Do some weight bearing on them because we want to counteract a specific pathology.
Does it start with an O?
Yes. That's a symptom. Osteoporosis. Okay. So we don't want to have additional easy fractures. Okay, we want to keep those bones strong. All right. And yes, orthostatic. So the orthostatic hypotension, we want to use the tilt table because if they've had a spinal cord injury, they've probably been in some traumatic event that happened and they've been laying down and they might be, having to be treated for other things as well. And so it's a while before they start getting up. Okay. And They might be in a bed if they can't transfer. We haven't taught them to do that, or bed mobility. So we really got to be careful of that. All right. After being in bed for 3 days, I had orthostatic hypotension. That's how quick it happens. Okay. I went in on like 9 o'clock, 9:30 on Friday, and went to stand up at about 9:30 on Monday. And I was like, I'm going down. Because I'm like, I'm going down. Going down. Huh? Yeah. So that's how quickly that can happen. Plus, they probably have them on drugs and all kinds of other stuff. I was very drugged out. What other complications? Skin breakdown because of incontinence and positioning, but what also can cause skin breakdown?
Atrophy.
Mm-mm. Mm-mm.
What's the letter?
You're moving them around.
Like clothing, wrinkled clothing.
Yes, shear. Skin shear or pressure. Okay. So pressure. So positioning is going to be so very important in all those kind of things. Okay. Anybody think of anything else? I can't think of anything else that goes with spinal cord injury as far as precautions and contraindications. Can you guys think of anything else? No? All right. So your Asia scale. Where is the Asia scale in here? Yeah, and if you go onto page 275 in here, respiratory stuff, so you can be doing breathing exercises with them. It talks about the cushions and the mobility, pain management. If they're an incomplete and you're dealing with pain, you could be using TENS. Remember all those kind of things, gait training when they're a lumbar, all that kind of stuff. 263?
69.
269. Okay.
Oh.
All right. So what is your Asia A? Your Asia A is what we've been pretty much talking about, right? Okay. So Asia scale. Time is it? Oh my God. Okay. Your A is complete. What is your B? Okay. So sensory incomplete. What is your C? Motor. So they have sensory?
Yes.
Okay, so just the motor. So remember we talked about the spinal cord tracts? Okay. So it might be something where they've gotten more of an injury in the ventral section of it as opposed to the dorsal section. See how that relates? Okay. Well, this one is going to be more dorsal injury rather than a ventral injury. See how that works, guys? Okay. That was your C.
Motor is gone or motor is there?
Motor is affected. Okay, so sensory is affected and motor is affected. Okay.
I'm reading this as B, you have.
Do I have it backwards?
No motor, but you have some sensory.
Oh, I'm sorry. That's what I meant. You have sensory, you don't have motor. Yes, Izzy messed me up.
It's all your fault.
Freaking ruined it.
How
Yep.
freaking dare I?
Yeah. Yes. So yes, this is the sensory is affect. The motor is, you still have sensory, and this one is, but you have no motor. Okay. No motor. And this one is, you have motor, but no sensory. Okay. Yep. There we go. Sorry about that. Yep. And then what's a D?
The water incomplete for less than half.
Of what muscle grade? 3. Yep. So it's, do they have sensory? Okay. I think they have some sensory. But the biggest thing is that their motor is incomplete, okay? And they have less than half,
No more than half.
more, I'm sorry. I thought one of them was,
No, no, no.
yeah, I thought it was less than half. You guys, they are messing me up.
Come on, you're the.
Well, I said that. And then he's like, no, more than half. And I'm like, huh? So,
Well, he was testing you.
ah. So less than half of the muscles are grade 3
Got him.
or above. So half or more, half plus. Okay. Jesus Christ, I should just read it myself. Yes, I should, with at least half being, so it's equal to or greater than, there we go, half. I know, it's getting to be a longer day. And then what is an E? We're all E's. E is normal. Is normal. Okay. And you guys remember how to figure that out? Like what level? Do you remember how that level gets figured out? But you're not going to have to worry about figuring it out because they're going to tell you what level it's at. Well, the PT doesn't even usually do that. It's usually done by like the neurologist before we even see him for therapy. Okay. Everybody.
So for like B, when it says 3 levels below the motor level, so is it like the level that got injured and then 3 levels below it? Am I just making stuff up?
Sensory is preserved below the neurological level. So so sensory is going to be there no matter what. No motor is preserved more than 3 levels below the motor level on either side of the body. You know what? I've always remembered it is they have sensory but no motor.
Okay.
From that level. Yeah. Don't get specific on this. Know if they have sensory but they're having motor issues, they are a B. Okay. If they've got no motor and no sensory, they're an A. Okay. If they have motor but no sensory, they're a C. That's how I remember it. Okay. I don't get into the itty bitty gritty because you got too many other things to remember. It's going to blow your minds. Okay. Makes sense? Okay. All right. So let's get into, everybody good with that? Okay. All right. So, anterior cord. All right, somebody else come up here and write up the different syndromes. Anterior, Brown-Séquard's, cauda-equina, central cord, and posterior cord. No, purple or blue, red or green.
This one.
You can have any of them. You can blue, and I've got green and maroon.
I might change it up.
Okay, you can. You can change them for each of them. See how I did in here?
Perfect.
All right.
All right. So where are we?
Anterior cord. So all of these that we're talking about, are they complete or incomplete lesions? Incomplete. Yes. Yes. Good answer. Okay. So an anterior cord, what's affected?
Loss of motor function and temperature.
Yep. Pain and temperature where?
That's what those lesions.
Right. Okay. And notice it says corticospinal and spinal thalamic tracts. They're not going to ask you those questions, but see how that relates back. Okay, especially the pain and temp, because wasn't spinal thalamic pain and temp? Yes. And corticospinal, wasn't that motor function? Voluntary motor function because of the primary motor cortex it goes up to? See how that makes sense? Okay. All right, brown dash.
Brown.
Yeah, SEQU.
Not Squidward.
SEQUARD apostrophe S.
This is the one I very rare.
Okay, what causes a brown sequence?
Severe
It's that one.
penetrating injury.
Let's say a stab wound. Stab wound or some kind of trauma.
What was the
Penetrating
injury
injury.
for the anterior cord again?
Compression. And it damages the anterior part.
Very rare.
Anterior gums usually with cervical flexion, so you're going to be more up. I don't know.
Directly.
Okay, yeah, to the spine. All right, so what do they lose?
Pain and temperature sensation.
So they lose
On the opposite side of the injury.
They lose sense, distant sense on the side of the lesion. On the other side, they have.
Yep. So they have paralysis of vibration and position on the same side.
You read that wrong. There's paralysis.
Same
loss of
side.
sense, and then there's also loss of pain and temperature on the opposite side.
Yes.
Imagine me.
Same side paralysis and vibration and positional sense. And positional sense. So paralysis because it's the corticospinal tract, okay? And pain or vibration and position issues because of the dorsal columns, remember? Okay. Opposite side, it's pain, loss of pain and temperature because of the spinal thalamic tract. And temperature, yeah, loss of pain and temperature.
I also have it. The patient loses movement and some type of sensation below the level of injury on the injured side. Is that correct?
Well, some type of sensation on the same side. Yeah, a vibration is going to be a sensation. They're going to lose that. Okay. And paralysis is going to be they're going to lose motor on the same side. So you're saying that either the knife went through the right side of their spine or the left side of their spine, not directly through the middle. Why would it be more difficult to go directly through the middle of the spine? Think about it more. Think about
Paraspinal.
yeah, nope, not the paraspinals, but you have what in the vertebrae back there? Well, the dorsal comes on the outside, but what sits back on the back of your spine? Well, people are super skinny, and you go ahead and see these bumps that go all the way down their spinous process. So they have to get through the spinous process, okay, or actually hit right in the very middle where in that little area between each vertebrae. But that's not even going to work because they kind of, the spinous process articulate down, okay? So the middle part is kind of protected, right? So it's going to have to be on one side or the other more to get through. And they go through the front. Okay. Cauda equina. You got that. Good job. What do we know about the cauda equina? What is a huge characteristic about? Yes, it means horse's tail. What else? Thank you. So there is more, I think there is a greater chance of them walking, right? Because it's cauda equina is peripheral nervous system, which can regenerate. Where does a cauda equina start?
See you later.
L1. Yep, L1. Okay, starts at L1. Okay. So it's peripheral, not central nervous system. What are you going to see?
Placidity,
Mm-hmm.
possible paralysis.
Mm-hmm. Because it's so far down, probably bowel and bladder issues. Okay.
Could be asymmetrical.
Could be asymmetrical. Yep. May not be exactly the same, except for the bowel and bladder. That's probably going to be symmetrical. It's always going to be incomplete because there's so many that come through, correct? Okay. All right.
No bowel bladder control.
No bowel and bladder control. Yep.
What's the injury again for this one?
Yep. They don't. Yeah, they don't really. It's. Yeah. Okay. What central cord? Yep, central cord.
Actually, it says the most common cause of cauda equina syndrome is significant disc herniation. Really?
There you go.
Where's that? Yeah,
Mhm.
I wrote it in my notes from third semester, week 7,
Thanks, Amber.
which it probably came from Miss Lisa's slideshow.
Okay, so central cord syndrome. Okay, it's usually done by cervical hyperextension. Okay, so it goes ahead and affects the spinothalamic tract. So what are you going to see? Spinothalamic. We've gone over this a million times. Pain and temperature. It also affects the corticospinal tract. So what are you going to see? Yep, motor, corticospinal. So it's motor. So it's involuntary skeletal muscle movement, right? Central. And then it also affects the dorsal columns. Proprioception and vibration. Okay, so those are the deficits you're going to see. Mainly, I mean, there is some motor, but also sensory. More motor than sensory, and more involvement of the lower extremities than upper extremities. So I always think central cord, cervical. Okay. So more involvement of upper extremities than lower extremities. More involvement of upper extremities than lower extremities. Yeah, than lower. Yeah. All right. Last one. Posterior cord syndrome. So that's usually caused, it's rare. They're probably not even going to ask you about posterior cord, but it is rare. Okay. Usually compression of the posterior spinal artery. So the arteries that go up there. Proprioception, 2-point discrimination, sterignosis. So it's all sensory and your motor is preserved. Any questions on that? I know. What time do we start? Okay, I think it's time for a break. Any questions on that? Does that help a little bit for a review of spinal cord injury? Okay. And how to treat it and what to do with it. And then I'm going to let you think up how you would treat these, what their functional abilities would be, all that kind of stuff. Okay? What they might have to use for mobility, what you might have to use for transfers, for walking, any of that kind of stuff. Okay? All right. I know, because you're all falling asleep. So it's like 12:54. So let's take a 10-minute break. Well, let's make it 1:05 just to make life easier. Okay. And then we'll get into TBI. TBI. Huh? What'd you say? I do like teaching this stuff. I just, think I haven't taught in months, So it's like teaching wears me out. These guys were at clinicals, and Tim was teaching, the freshman. Tim, I know you guys haven't met Tim.
His name is Tiny Tim.
Who's Tim?
Tim is the new professor. He replaced Sam. No, he's a PTA. Yeah.
How old is he?
I think he's.
How old do you think he is?
No, he told me how old he was. He's a little bit younger than I am, late 50s, early 60s. He's about Sam's age. He's about the same age Sam was. Because that was Sam's age. No. But he's a really nice guy. Yeah. I liked him a lot.
I need agua. I'm parched. I'm so parched.
Ugh.
I'll take the cup that I lost last week.
TBI, pathology. I'm never going to make this through. That's quick. Oh, you are very welcome. So I know what I'm talking about when I do this. I'm worried about the ortho ones. I got to figure that out. Probably get more into that later, so that should be fairly quick. And I want to cover this. So I might switch and do it this way.
What do we have to go over? Pathologies? Or brain injury?
We're going to go over pathologies. We're going to go TBI next. And then,
I like how you set up this review better.
huh?
I said I like how you set up the review.
Oh, good. Thank you. Well, I thought about it a little bit, so gave me a chance
Honestly,
to.
just straight to the point stuff, really.
Good.
Because everything's going to be in a how to treat the patient anyways.
Exactly.
So just knowing it helps.
So that's, you have to know the basics in order to know what's affected and how to treat it. So that's pretty much what I'm trying to do with you guys. Okay, good. Good. I think it's better than how I used to do it.
Yeah. There's a lot more information last time. But it's specifics.
Yeah, because there's no way that I have time to go over everything. Yeah.
What time does Shane?
Huh?
What time is Shane coming?
Shane coming for what? Oh, I just found out about that. 3? I think 3:30.
Talk about Cora. Where are you going to work, Izzy?
I'm working at Citrus Orthopedic right now. It's like hypertension and stuff.
What is his name?
Josh.
Is it in Citra?
It's in like wherever area.
Josh Marco.
Marcotte.
Yeah. See, I just
I
couldn't.
love it there.
He is such a nice guy. I really like
He's
him.
fun.
He is a lot of fun.
I
She-
used to live in Hernando, but then I moved to Ocala. But it's like my CI reached back out and he was like, "Do you want to work as a tech before you smash your doors?" And I was like, "Yeah."
Because they loved her out there. They loved her.
It's a drive out there.
It is, but I just got a house over there, so like close to Inverness. So the plan is to pass. Then I work like 15 minutes.
That'll be nice. They're also part of the Orthopedic Institute.
Yeah, we work like with the surgeons like right next door. So if you have questions, if you're waiting, you can just go next one. faster PTAs and stuff.
which is nice.
Yeah, very nice.
Very convenient.
Very.
Very convenient. Yes. Very, very convenient.
Taking a lot of patients too last minute, but it's still fun. I like it.
Good.
Actually see them get better, which I like a lot.
Yeah. That is nice.
Two bricks on together.
And the doctors really want you to go there. Like I wasn't going there because to the Orthopedic Institute because it's too far for me. They are.
Petrella and then Chapman's really good.
Of course.
Yeah, great. Well, he does a lot of younger kids. Like he's doing a lot of ACLs and stuff.
Really?
Kids, yeah.
Yeah.
A lot of sports.
I've worked with Petrella.
Have you? A lot of
He does it
people.
better.
The CR I worked for.
He does it better.
Okay, you guys feel right, so she didn't like it. Because he was like the short fall, or you can't make patients go to your practice and all that. We still have to do it.
No.
So I can understand that, and I didn't know until I worked with Josh. I'm like, oh, that's like Petrolla's problem.
We're in a group
chat right now.
And everybody, so what did they call it? A POP, physician-owned practice.
Yeah, like
You're pretty much in, and so,
you're gonna take out everybody else. Please. Like you, we all know you're gonna
Yeah.
voice your opinion anyway.
so APTA doesn't like POPs. You know, American Physical Therapy Association, they don't like POPs because the reason they don't like POPs is because it makes us less autonomous.
And it takes away their, you know.
Yeah.
They're good.
There's gummy worms there. There were. Huh?
I saw that. They're like healthy ones.
Yes, they're juicy gummy worms.
That's just what I needed.
I had them for my dirt cake.
Oh, is that what they were from?
Yeah.
Fabulous. I love that.
Yeah.
And I got so much because I was going to share it with Izzy, and then she didn't eat it. So, see what? I ate all of it.
So I will tell you a funny but a gross story about that.
Okay. I don't know if I want to hear it.
So I made the dirt cake, right, on Tuesday. And then on Wednesday,
Diarrhea.
I came down with the norovirus. So I was
No.
here, right here. Like I was in school here trying to figure out. Well, right before that, like my stomach was feeling really acidic and I really didn't get to taste the dirt cake. So, oh yeah.
What medications do you on, honestly?
No, it wasn't that. So I went ahead and I had like about this much of the dirt cake before I started throwing up. But I will tell you, it made it taste so much better. And I know that's gross. It is a crazy statement, but I know that's gross. But I remember throwing up going, thank God I ate the dirt cake.
Honestly, sometimes I'd rather just throw it up than have that stomach ache. I
Yeah.
get the worst thing ever.
You gotta listen to it.
Who's Kieran?
I've never heard of them. They found me on Indeed. They just called me.
Huh?
I said,
Well,
"I'll
look
go
at how
meet them."
quickly that happened. Oh, well, I know because you're on Indeed. I know. Remember, I told you I get 2-3 offers a day. Yeah,
Those are good, aren't they?
They're so good. They have like
20 minutes from my house.
Yeah, they have
that's awesome.
inside.
She literally looked it up right now while I was on the phone.
Oh my God.
It comes with like
Is that a thing?
four.
Healthy gushers?
Yeah, so it's important to figure out what you're going to eat before you get sick.
They're really
Sorry.
good. Oh, why, Rebecca?
Okay, we're missing Raul. Oh, nice job. Nice. So we're just missing Raul.
Always Raoul, man.
Yeah, everybody knows Raul in here. That's true. I didn't realize that.
Yeah, we all know each other.
I know.
Actually,
And you guys competed against each other.
we sure
Can't
did.
really say that much for the.
You guys.
Yeah, we don't remember all of them.
What?
Freshmen. You guys haven't even met them. Yeah, the freshmen are already.
We've never met them.
I can't remember all
You
of
feel
them.
like the big dogs now, don't you?
We can't even remember.
You can totally tell by their attitude.
Oh yeah, big dog.
They definitely have big dog attitude. They're like, yeah.
I always have a big dog energy.
Yeah, yeah. Do you remember how cocky they came back? Like this
We
crew?
were cocky when we came
Hold on,
in.
we also remember when they
Second
came
semester.
Let's be honest.
Honestly, so the first thing Isabella ever said to me was, "We should work on depression because you're depressed." Well, she was telling me about.
Who said that?
That's the first thing she ever said to me.
We should work on depression because you're depressed? I never got that opinion.
Well,
Ever of
I
you.
had gone through a breakup, and then she's
Oh.
to say that, not appropriate.
I am having flashbacks.
That's why we're close now.
Yes, I am having flashbacks because Izzy giggles as much through the review as she does through class. Gigglehead. Yes. Okay. So let's get back to TBI. All right. Obviously, looking at this, what is the first thing we want to know about our patient before we start treating them? Oh, I didn't hand you out these. 277. I am comfortable now. Thank you. All right, so I'll give you the answer. The Rancho Los Amigos scale. Yes. Ugh. Why is it important for us to know this scale?
To know the attitude and the attitude.
Yes. Is it going to affect our treatment?
Yes.
Yes, it will be. Is it going to affect how we treat that person? Yes, it will. It is page 277. No, there is an 8. Ugh. Yes. Okay. So, again, remember like we did this, I went through the motor control return, the return for motor control, and I said if you like remember 3, okay, it's easy to figure out the other 2. Like I've shown you some of those. All right. So, which one do you think you might remember here? Number 4. Yes. Number 4. Yeah.
277 and
278. So what's number 4?
confused, agitated.
Okay. And why do we usually,
They're gonna swing on it.
well, and that's usually kind of where we start to get them, right? Is confused. Are we going to see somebody at no response? Okay. Maybe.
Your home health?
Acute care? Maybe. What would we do with them with no response? Passive range of motion? What else? Positioning. Pressure relief, positioning, passive range of motion. Yes. Maybe a little education. Okay. What is going to complicate our positioning techniques with TBI patients? What usually comes along more than just their state of recovery, cognitive function? What happens? They're a TBI patient. No. Nope.
Wait, ask the question.
What comes with them?
What? Okay, I'll try to rephrase that. So usually when you see a TBI patient, okay, they just had a traumatic brain injury. How do they get that traumatic brain injury?
Whiplash.
Car accident, trauma, okay? So it's usually they get it with a car accident, okay? Some kind of trauma. Remember the blast? Yeah, blast, not gunshots. So like a blast injury. Remember coup, contra coup? Brain goes in the front, smashes in the back. Okay, that kind of stuff. All right. So yeah, we can see it a lot with soldiers. It can be an open injury. Okay, where literally there has been some kind of penetration to the skull. That's where you might get your gunshot. Or a closed injury. Yep. So concussions, hematomas. Okay.
When they gave us the deep freezer? Yeah, I remember.
What are you guys talking about?
Back in the when I lived in Palm Coast, remember she told the story in your class where this lady gave him a deep freezer, but really she got shot in the back of the head. Whoa! My neighbors gave me the deep freezer first, and then like that's how the story started. Like okay, months later, the husband shot the lady in the back of the head, and then he killed himself. But he died. But she ended up living. She was still like doing all her garden stuff.
Oh,
She lived, so.
that's all. I don't remember that story.
Yeah, what does the freezer have to do with
Do you
it?
remember that one?
This is how she brought them up.
No.
There's no way.
No, I don't.
That's right. That's when we were trying to figure out the difference between your
PNS
different
and your-
systems, your peripheral nervous system and
What?
your.
It was your firefly.
Oh, the fight. But it's about being chased by a bear, not by a bear
Right,
pooping in the
that's where
woods.
she got confused.
Oh, okay.
That's where the confusion set.
No wonder I'm confused. Okay, so no response. So we're going to probably do passive range of motion, and we're going to do positioning, just in case they talk to you about that or ask you. Okay, generalized response. What does that mean?
Like the light
No. Generalized response.
Short, simple answers.
No.
They're inconsistent and non-purposeful.
Yeah.
Yes. So you give them some kind of stimulus and they might respond to it, but not all the time. Okay. Or they might not respond appropriately to it, that kind of stuff. That's no response. I figured that was self-explanatory, so I wasn't going over it. But then since we have the bear issue, maybe I should have responded. Okay. Localized response. What's localized response?
They follow simple commands.
Yes. Like you ask them to close their eyes, they close. Remember I showed you that video of that kid who got in a car accident, a really bad car accident, right? Okay. And it actually showed, it's like one of the best videos I've ever seen where it shows the progression of him coming out of this. It does make me cry. And then he fully recovers in the end. Okay. Squeezing your hand. Okay. Could be inconsistent. It could be delayed, but they are able to follow simple commands. So this is simple commands. Can we see them here? Do anything with them here? Maybe. Yeah. You can still be doing all this stuff, but if you just give them like one simple command, like lift, flex your hand, lift your hand, open your hand, open your hand, open your hand, squeeze, squeeze. You could be working on different things. Okay. Right, but I'm just giving you examples of it. All right.
Did they learn like all the different practices, like serial practice, block practice, all
Yes.
of that? Because that is going to be stuff in there.
Yes. Yeah. So that's all a lot. And remember that? Serial practice, block practice. Remember those? Okay. So what's blocked practice? Same thing.
Yeah.
Yep. Do you do it constantly?
Over and over.
Oh, so you just like for an hour, I just do the same thing over and over again. Wow. I'm exhausted.
Yeah, that's
No, remember it's a blocked period of time. So you block it for like, they do 10 reps and then they rest. And then 10 reps and then they rest. So you might be doing block practices with somebody here. Okay. Squeeze, 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 squeeze. Give them a break. Okay. Squeeze, squeeze, give them a break. Okay. Then serial practice, wasn't that where they just
That was the one where
they continue to do it over and over and over and over and over again? Random practice. So remember what random practice was? You're doing multiple things. You're practicing different things randomly
In a random order.
in a random order.
Because then you have variable practice, which is a variety, mass practice, continuous practice with small amounts of rest time, and mental practice, which is
Cognitively figuring it, cognitively running it through your head before you actually do the activity. Okay. Yeah, make sure you know those. And why do you want to know those? Because remember when we talked about them recovering from a CVA? And that's why I don't have time to go through all the theory and all that kind of stuff. All right, you got to know those theories which go to your treatment and when it is appropriate to do each. Okay. So to do random practice on somebody who is confused and agitated or can only follow simple commands, do you think that would be a good thing to do? No, you're probably just going to do blocked, repetitive practice, short periods of time, because these people, they get really agitated. Huh? Yeah. Yep. Okay, so confused and inappropriate. What does that mean? Yeah, the responses don't make sense. They can have inappropriate responses. Yep, impulsive. Safety's a big issue, right? Ugh. Yep. Confused and agitated too. They're easily agitated and irritated. If something bothers them, like I will tell you, they probably will get headaches often. So they start to get a headache and you're pushing them to get your hour in. Good luck. Okay, they're going to get really agitated with you. Okay. And they don't understand why they're doing this anyways. They may not understand the extremes of their injuries, which goes back to here. So what is, when you're doing all of this, things that affect it with this, what is this stuff going to cause? Secondary injuries, right? Okay. So you might be dealing with what? Secondary injuries from a car accident. What? Thank you. Fractures. Fractures, definitely. Okay. Yep. Short-term memory loss. Well, that goes back to this part. Oh, loss. Short-term memory loss. Okay. Open wounds. Could you have open wounds, burns that you're going to have to take into consideration? Fractures, short-term memory loss, open wounds, burns. What else? Whiplash. Yep. Other musculoskeletal issue. Soft tissue issues. Soft tissue. Pain. You're probably dealing with pain. Lots of pain. Okay. So that's part of what makes it also so difficult to treat a TBI. They're a complex patient. You know, they're not your easiest patients because you got to deal with all this cognitive stuff and then you got to deal with all of that at the same time. So it gets to be very taxing to deal with all of it. Okay. It can be simple. I had a guy that went in and they did a craniotomy. Did he have a tumor? I think he had a tumor. And they took the tumor out. And most of the time, fatigue is another one. He wanted to sleep a lot when you brought him down. Okay. And then he would be up yelling at night. Yeah.
Well, concussions are not supposed to let them sleep, right?
Right.
I had a question. Well, I guess it wasn't that test, but like just like a regular test, but they said not, or one of them was like let them come back after 2 to 3 days, but one of the other answers was let them, or don't let them sleep, and that's the one I picked, and they said that one was wrong.
That they're not supposed. Yeah, they're not. You're supposed to keep them awake. Yeah, you're.
For like a day, or like.
I think it's only a day. It's like overnight,
Yeah, I mean, so I got that one wrong.
24 hours.
Yeah, because what does it do?
Well, they could just pass away in their sleep. You don't know, because it could be that they have, if they have a concussion, it's an injury to the head. So they could have encephalopathy. They could have a brain bleed. If they're sleeping, you're not going to be able to tell if they're having any changes that could say that they're having a hemorrhagic CVA. Yeah. What was the right answer?
I have to find it, but it was like let them come back to the sport or like get checked
Okay,
out
so it's
for
return to
3 days.
sport.
Yeah.
It's return to sport. That's not about falling asleep.
But even if you have a concussion to the sport, you wouldn't let them go to sleep after concussion.
So there was a whole return to sport thing. Like, they really shouldn't be falling asleep. You really want to be monitoring them for 24 hours after that. Yeah. I don't know why they said that, but it's usually a week before they return to the sport, remember? Then they have to get checked out, and it's the doctor that chooses to return them, not us. Huh? Yeah, there was distinct protocols of which you would go ahead and start increasing their levels of activity. Yes, if they can't tolerate it, they go step back down. Yes. Oh, what? Pass a test. Yeah, to come back. Yeah. So, yeah, I don't know why that would be, because that's not in any of the protocol that we teach you. It's not involved in it. Yeah. That's more of a return to sport protocol as opposed to standard. Standard protocol is sleeping. That's what I always thought too. Yeah. I don't know. I don't know why they did that. I do not know. I'd have to look that up. All right, so 5, confused and inappropriate, right? Okay. So they're still confused while they're there. Okay. And their actions, they're doing more definite actions, but they're inappropriate. Okay, they're not always true to what they should be. They're not following orders distinctly. Okay. Okay, so here comes our favorite, right? 6, what is it? Okay. 7, appropriate. So what does that mean? Robot-like. Yep. Knowing what to do and going through the actions, but not thinking a lot about it. And then purposeful and appropriate. Yeah, pretty much back to normal. Okay, so to remember these, remember I said confused and agitated, I always remember as being number 4. I never forget that, okay? Then your next 2 are still confused, all right? So you're going to be inappropriate because you've gone from being agitated, but now you're inappropriate before you get to be appropriate. So it's easy for me to remember 4, 5, and 6. Okay? Got that? Because they're all confused. All right? I know 1 is no response. And if I had to choose between generalized and localized response, if those were my possible answers for number 2, okay? Generalized is like much bigger. So there's like a wider area for them to possibly get the answer right. Well, this is a much smaller chance of getting the answer right. It's local, okay? So that's why I think this is a lot vaguer than this, correct? Doesn't that make sense? Okay. So then after I get out through the confused, I know that this is the end. Purposeful, appropriate is the end. Automatic, appropriate, which is your robot one. So it's appropriate, but you've got to decide between those 2. Most of the time, I think you end up being asked about these, don't you? Yeah. So these are your 3 main ones that you end up working with. By the time we get into these, they're probably sent out into the community, okay? Like they're in a community facility where they're doing back to work stuff, back to life stuff, all those kind of things. We're not dealing with them as much, okay, as you would in a rehab or acute setting. So this really is probably going to be acute setting, and this is going to be subacute, like a rehab setting. And then this is going to be into your like community integration settings.
I would rather generalize than localize treatments.
I said that. Oh, no, the generalized and so goes. Okay. Okay. Well, we know these are simple commands. Community integration settings. All right. And so then again, talking to them, how are you going to talk to them in these? Think about that. When they're confused and agitated or even confused and appropriate, are you going to be like giving them multi-step commands? No, simple one-step commands, okay? You could start doing more multi-step stuff with definitely here a little bit, but definitely when you're getting down here, they're going to be doing more multi-step commands.
So what would you do for generalized response?
For generalized,
Non-purposeful stimuli yet inconsistent.
so remember that I said what I would do for it, or what you're doing is more, you're going to do more passive range of motion and positioning. You could do some stimulus stuff, but we're probably not going to do that. Family education is going to fall in here. You can educate the families about this if nobody's talked to them about it. Maybe. Depends on who's on your team within your scope of practice. Okay? But at least you know those kind of things. All right? Make sure you know whether they're the types of injuries, which we just talked about. Open, closed, primary with a coup, contra coup, so they initially get injured, okay, because the blast hits them and then they fall back and it hits the back, okay. Secondary injury, so from that banging around in your skull, you can end up with a hematoma, all right. That is going to cause issues. Know your levels of consciousness. Know them confidently. Okay? So they're in a coma, then they come to a stupor, all right, which is basically that they're unresponsive, but they're kind of arousing a little bit. Abdomnity, I can't even pronounce it, where they do a lot of sleeping. They could have some delirium, clouding of consciousness, and then they become fully aware when they're conscious. All right. You guys remember the Glasgow Coma Scale? Okay. So basically looking at what level they're in for the brain injury rating. So if they're between a 9 to a 12, they're moderate. I would know those just in case they ask you that. And if they're a 13 to a 15, they're mild. Remember, it involves eye opening, motor responses, and verbal responses, and you add those all together. All right, does that help you guys a little bit? Sure. Okay. All right, time is it? 1:28. Okay. All right, so let's go through pathologies, because the last two things I have for you are peripheral nerve injuries, which is basically understanding about the severing of the peripheral nerves. To get into specific peripheral stuff, we're going to talk about that a little bit more in ortho, in the ortho review. Okay? And the peripheral nerve injuries that are essential to you, I actually am going to cover in the pathology part of it. All right? And then the last thing that's not on here that I did last night that I was like I was going to give you is going over the developmental milestones. Okay? So why don't we do that really quick and do developmental milestones and then spend the last hour doing pathologies? How's that sound? Okay. Okay. So, huh?
Next page is developmental milestone.
What'd you say? Next page is what?
All the reflexes.
All the reflexes? Yeah. Yeah. And I did that as well. You're going through the reflexes and stuff, and then your developmental milestones. So we'll do the milestones first, and then we'll come back to your reflexes. So I guess I'm going to hand you out. So the peripheral nerve injury one, you guys can pretty much do that. It's just, again, understanding peripheral nerve pathology and the levels of which the injuries are. Okay, so if it's completely cut, is it going to regenerate? Probably not. Okay. And that's the kind of stuff that you need to know. Why am I handing you only one of these at a time? I don't know either. Did I get a Raoul one?
We got one.
Yeah, but this is
Oh,
the.
not this one.
Yeah, I forgot to hand those out. Are you dying?
She's dead.
I know. Tell me about it. Oh. That was when I start. My legs getting tired. You're welcome. Are you teasing me about killing trees?
Kill all the trees.
Do they up your printing allowance?
No. So I always feel like if you have to write and fill out this stuff yourself, and you kind of group it from all of this mess,
Yes.
and only take it what's important to you, that I think it helps. Don't you agree?
Yes.
I was
And-
joking about it.
There's also
Ink is
last night.
expensive.
Huh?
Ink is expensive, so.
Ink is expensive. Hey, I haven't been here for. I haven't been here for months, so I have time to catch up on skilling trees. All right. So let's go over your developmental milestones. I gave you the time frames. Okay. So if you get a question though, the questions are probably not going to be at 12 months, what is a child capable of doing? Okay. The question might be more of at 12 months, they're just beginning to crawl. All right. Is that a normal developmental milestone? Those who had their pediatric rotations, tell me.
Oh, once you better be walking.
Yes. Usually they can stand up and start to walk. Okay. So 12 months is usually the one that I always remember as my midpoint. It's that walking point. I got to get them to walk. Every child wants to walk. Every person's got to walk. So around 12 months is when I want to get them to walk. Okay. So it'll say here on page 282, the range is between 6 to 14 months. Okay. Yes. I knew a friend of mine had two kids. They were like within 18 months of each other. I think at the maximum they were born within 18, less than that. And the second child was walking at 6 months. It was a disaster. She was so tiny. She was really tiny and petite, and she did not understand the meaning of the word no. Yeah.
She was the baby.
Because she was the baby and she was running after her sister all the time. She wanted to be with her sister. Yeah. So that's why they give you these averages, because some kids will walk really early and some kids will walk later. Okay. My girlfriend at 2 years, almost 2 years, her daughter was still struggling to walk. That's when they knew that she had gross motor function issues from the umbilical cord wrapped around her neck. She was also having issues with sight, and she was having issues with other motor language, speaking, those kind of things. Okay. But anyways, 12 months, walk. That's my biggest thing. Walk. Remember, at 12 months, you're going to start walking. Okay. You're going to pull yourself up and you're going to walk using furniture, probably. Huh? Well, walking with assistance, using the furniture on their own to walk. There doesn't have to be somebody holding their hand. By 15 months, they're usually walking on their own. Okay, standing alone, walking on their own. Is there a lot of delays because of it?
I mean, like, in the actual clinic, like when I work with peds,
Oh, really?
yeah, because all they want to do is hold their child, so they never learn it on their own.
I did not know that because I never did peds.
They're hard.
I
They're
don't.
fine. They're just telling them that.
There's like how many? You did peds, you did peds, you did peds, you did peds. Where'd you do peds?
First clinical rotation. It was
At Cora?
Yeah.
Oh, I didn't.
Yeah. Yvette works with Tortoise a lot.
Oh, that's right, because you're down in Silver Springs as well. I forget. Okay. You did not do peds, Jackie, and you didn't do peds, Carrie Moore. Okay. Well, that's interesting. Huh? Yeah. Because we had a hard time. We have a lot more places for peds now than we used to. Well, and we didn't even use your clinic because I had nobody over there. So
The developmental milestones in Big Red.
yes. If it's
I'm not finding it underneath developmental milestones, or pediatrics.
remember this,
Yes, I have that somewhere. Thanks.
you can steal it. That's your developmental milestones too, and your reflexes. And is it on the clipboard too? I know it's in that handout that you got when you got here. Yep. Thank y'all. And the reflexes are in on that too. Okay. So at 9 months, well, let's start from the beginning just so that you have an idea. So what needs to develop? Remember we talked about the development of the child, caudal to civil, something like that. So head to distal, like your head stuff, movements develop first before your leg movements develop. Remember that? No, everybody's looking at me like I'm insane. I'm not insane. Cephalic to caudal. Yeah, that's it. Thank you. So their head and upper extremity control develops before their lower extremity control. Okay, remember that. Cephalic to caudal. So your head and upper extremity develops before the caudal. That's why you don't come out of the womb like a horse and start walking within minutes. The what?
Horse feet.
Horse feet? Yeah, I know. They're kind of weird. But yeah. So the first thing you have to be able to do is lift your head up. I mean, pretty much when you hold a newborn, how much control do they have on their head? None. Yeah, it's very floppy. So they have to get that head control. If they didn't get that head control, what could happen to them? You just let their head constantly do this. Yeah, they could potentially end up with a brain injury, right? Or a spinal cord injury or something. So that's why at 2 months, they have to get that head control. Okay? And it's not so much this way. Okay, as they can easily have gravity help them flex, they have to get head extension. Without head extension, you cannot walk. Well, you can walk around, but you walk around like those people that do this. They walk around staring at the floor all the time. Okay? Yep. So that's the big thing I think about at 2 months is head control. Okay, very important, head control. Head control with belly time. You got to have belly time because having them on, if they're laying on their back and their arms, is that encouraging them to do cervical extension? No. If they're laying on their stomachs and they hear a noise because they are curious, it makes them want to lift their heads up and look around, right? And when they first do it, they lift it up and they're like, their heads are kind of wobbly all over the place. And then they start to build more control. All right. And that's what happens at 4 months. Okay. They start to have head control. Their heads are steady. And it involves more of the eating portion of it, hands to the mouth. Okay. It's all about survival, guys. Without those specific milestones, you're not going to survive. Okay. And then the next thing you need to get before you start walking is what? So you have head control. Now you need to get what? We even work on this with our CVA patients. Trunk control. So what do they have to develop to get some trunk control going on? Rolling, but core, specifically what? Specifically what muscles of the trunk? Flexors or extensors? The back extensors. So they're on their tummies and they try to push themselves up. So they start to push themselves up. Okay? So that's what happens at 4 months. So prone on elbows. I always think prone on elbows at 4 months. Okay? Steady head, prone on elbows. And feeding.
Are these the ones that are going to be like these answers are on the test?
Yes. Okay. But I'm just giving you how to condense them. What are going to be the most important ones? They're not going to say at 2 months, which is they're not going to really ask you more of at 2 months, which can the child do or whatever. I'm
It might. They'll be like, what can the child do at 6 months? Yeah, they're going to want to know the head control, rolling, sitting, creeping, walking.
exactly.
And then what can they do? When they get normal heel strike and when they get normal, when they can be assessed as a normal adult, which heel strike is 2 for tibialis anterior and regular gait is 7 years old. That's when they can be assessed.
And that's not even in here is the 7-year-old because this only takes us up to 5. And any of our stuff we've ever learned only takes us up to 5.
Well, 7's when they start to assess their gait as a normal adult.
Adult. Okay.
Playing with objects and what they can do.
Yeah. Okay. So at 6 months is when they get to roll. So they're developing more trunk control, correct? Rolling. I always think of rolling at 6 months. Rolling down the river, rolling in the deep. At 9 months is sitting. And then 12 months, we talked about pulling themselves up to stand and start to walk. At 15 months, they can take some steps on their own without furniture or anything. 18 months, they're pretty much walking out their own. They don't have to hold on to anybody or anything at all. But that's when they can start feeding themselves at 18 months. And climbing, feeding and climbing. Creeping. Why don't they have creeping in here?
I thought it was the same as the 9 months.
The 9 months, yeah, creeping.
Sitting and creeping.
Sitting and creeping, yes.
8 to 9 months.
8 to 9 months is sitting and creeping, yes. 24 months, heel strike, and they're kicking. 30 months, jumping. A lot more upper extremity, being able to take their clothes off, that kind of stuff. Turning pages, they start to getting more fine motor control, okay, with 8 to 30 months. I don't think we really need to worry about the 3 years, the 4 years. I know that they could catch a ball was a big thing at 4 years, and hopping was at 5 years. So we took a lot of the stuff that's in here and we condensed it down. Make sense? To be a little bit easier to remember. Okay? Any questions? Is that like a good quick review of developmental milestones for you guys? Okay. The other thing I did for you, so the important thing about reflexes is when they get integrated. Okay? Now there are certain reflexes that just persist. But the reason that the integrated, like your primitive reflexes getting integrated, is because when there is a injury, a brain injury, or a CVA, remember, those primitive reflexes come back. It's a central nervous system issue. You know that is essential, and that's the importance of those primitive reflexes not showing up and knowing when they should integrate. So a lot of the early ones are for pediatrics, but even the 5-year ones, if you're treating somebody who's had a CVA, they better not be showing those 5-year runs. The only things that they should be showing are the ones that persist. And that the persisting ones are not in your book. There's like 3 of them. They are on the handout sheet. Yes. And like writing reflex, like you're going to fall over and you automatically write yourself back up. Okay. So you're about to fall forward. Somebody hits you to push you forward and your body automatically reacts to push yourself backwards. Your hips react, everything. You don't think, okay, now I got to come back on my heels. I've got to thrust my hips forward. I need to go more upright. After you don't think about that. It just automatically happens. Okay. So those are those persistent reflexes that happen afterwards. Okay.
Rebecca, what did you say for 7?
That's where they evaluate them as a normal gait pattern. Yeah. Yeah. I hated the PEDS questions.
They have the kids come in for those too.
Mm-hmm.
Hurricane ruined it.
Oh, sorry, that was fun.
Did it?
We had
No.
it planned and then the hurricane.
You had what?
And then the hurricane,
Oh.
school got canceled. Also, we never were taught how to listen to lung breathing sounds. He was supposed to teach us that. You missed that too because of the
Yeah,
hurricane.
YouTube definitely for sure.
Yeah. We don't know that.
They're just gonna show you little clips anyways, and that's what the test would be. If they were to ask
Okay.
a question on that.
So is that what it meant when people said breathing techniques? Like I didn't understand that meant the.
I told her that when she came in for one of my clinical midterms. I already told her we didn't get taught it.
Okay, yeah, and it came back as breathing techniques. So when I sent it out to you guys, I was like asking questions, which nobody answered my questions. So
I've never gotten a video or anything like that for those types of questions. They would just say like what noise you hear.
crackles, rails.
Yeah, I feel like that. Because every single time I've gone in, they're like, "There's no audio to your test." That's what they tell me. Somebody told me something.
So it would say, what would you hear for what though? Like.
So is it asking you to hear the lobes?
It won't ask you to hear. I'm just gonna say
Like which
in
lobe?
this condition, what do you hear?
Okay,
like
so
if you have fluid in or something in the higher area of the airway.
so breath sounds.
Right, exactly.
So know which one's crackling versus wheezing.
Exactly. Wheezing is like deeper
Okay.
secretions, and then the crackling is higher in the airway. But YouTube will show you that. The nurse lady, whatever her name is, Nurse Rachel, whoever. I think you guys have seen some of her videos because they showed us anyways. But she does audio sounds and tells you what they are.
Well, there you go.
That's a good idea.
Okay. All right, so we're gonna do these primitive reflexes really quickly. Do they go into a lot of reflexes?
No.
I didn't think they did. Yes.
What? Mine they did. Asking, doing reflexes? Not to do them, but that's what she's asking.
The primitive reflexes, what they are.
Like
Asymmetrical tonic and the symmetrical tonics are going to be important.
We had one of them on the practice there.
Okay. Palmar grasp one is going to be important because that's going to be where you put the pressure in their hand and they go ahead and automatically clasp. Yes. You can go ahead and you can read through these and see what it says about it. Okay. I would condense it down. So like I always think Palmar, you put pressure on the hand that's supposed to close into a grip.
Your tonic labrum,
Yes.
the one, the ATNR and the STNR. Yeah.
Yeah, the ATNR, the STNR, and probably the tonic labyrinth one I would know.
And the Batsky sign.
Babinski.
Yeah, especially with that one for sure.
Isn't that
for adults and children?
plantar? Isn't that part of the
That's
plantar?
when your big toe extends and your toes fan out.
When you go ahead and slide.
Yeah.
Yeah, slide up on the bottom of that. Yeah. Babinski. Babinski. So those are the big ones. The rest of this stuff is going to be like rooting, is so that the child, like you touch their cheek and they try to search for the finger. The Morrow reflex, that's the one where you drop them suddenly. Like they always do that one last because they start screaming and crying. What are you laughing at? Did you have that in your clinical? Yeah, always me. Startle. So I always startle's easy. You give them a sudden noise and they, it's an automatic reflex. Somebody startles you, you don't just sit there like this unless you're catatonic. Okay. Positive support. You put they're waiting on the ball of their foot and they're trying to balance kind of thing. Remember that? They get that proprioception in through there. There was a lot of videos that we had shown you of those guys. And then stepping, where you're kind of like they're like moving one leg. You move the one leg, then they end up moving the other leg. It's a stepping kind of reflex thing that they do with you. Okay. A lot, huh? I know. It is neuro. All right. Do you guys want to take a break? Good. And then we can come back and do pathology. I only have 30 minutes to do pathology. Come back at 2. Cannot believe I made it through these. Oh, ow. Ouch, ouch. Ugh. I'm laughing at myself because I just keep making noises. Oh, my back is killing me. Unfortunately, I think when I did these sheets, I didn't go by your gold and your silver and your bronze when I laid them out. I did on your questions, but I didn't do it on these sheets.
I don't even see that one that Rebecca was talking about.
Which one?
Babinski.
Babinski, it's a test.
Oh.
It says it somewhere in here. I can't remember where it says it, but it says it, yeah, and you do that. Like I've done that for central nervous system as well as for testing on older adults. You run a pencil up the bottom of the foot and they fan their foot out.
Is that like using the what's that thing called? For sharp or dull?
You could. Yeah, but you usually use like a pencil or something. Like you're not going to take something super sharp and do that.
The other thing that we had when we did those tests, we did the sharp, the dull, and then we had that.
We did sharp, dull, white, light touch, Semmes Weinstein. That's in here. That's where you go ahead and test different areas on the bottom of their foot with the filaments.
Okay, that's what
Yeah. No, this is where like, this is the foot, okay? And somebody has got their foot relaxed, toes are slightly flexed, and you take, like I could take the edge of this and do this, and their toes should, yeah.
Okay.
Okay. And if they don't have that, then it's usually a sign of a upper motor neuron issue. I don't remember. I saw it in this book somewhere, and now I can't remember where I saw it.
The first time, do I get water? You just hold my hand while I do it. The first time,
I had to find out where that is.
Unless they're calling it a brush test.
Where did you see the brush test? No, there is one in here that says Babinski reflex. Yes, yes. Huh? The B, B-A-B, Babinski. It's the Babinski test.
What's the man's name who bought out Lisa Central?
Jacob? The,
He wants me to follow Ray.
oh, cool.
He didn't know if I could do it before or after the boards. He's like, I don't know.
You can shadow without having taken the boards.
He didn't know if I could for shadowing.
By their schedule or legally?
Legally.
Legally, you can. You can't touch a patient. You're just going to watch.
You know Jacob, right?
Yes. You can't touch a patient. You're just going to watch. You're not going to treat. You're not going to do, you're just going to, it would be the same thing as if you went into your school, like into your pre stuff and shadowed.
Ray said if he doesn't get back to me, then let Ray know and he'll get on.
He will. Him shadowing Ray.
He wants me to follow Ray. He bought over Lisa Central.
They didn't really buy it out. Everybody's saying that. They partnered. Yeah, they have, like, they're controlling partners now, I think. Are you going to do that?
Shadow control.
Yeah, she's coming. Yeah, they're coming in. So they're coming in for your mock interviews in week 7. Just Lisa. Okay.
What's the outpatient and inpatient?
Outpatient is
That's, yeah.
And what's the inpatient?
the inpatient one.
TMC, like Oak Hammock, the company you went through for Oak Hammock, TMC. They're going to do a virtual.
Yeah, they're doing virtual.
So they're all the companies already talking to me. Bring in 3 new ones.
Sorry. There is a new one that
I like
wanted to see if we could get it in. Yeah, TMC is, I think. Is it around her?
I don't know. I said see if it is.
I don't think it is.
There was more in Gainesville, but apparently they shut down. So.
Really?
But they were like affiliated with nursing homes that shut down.
Interesting.
One in Tampa that we did that Zoom call with.
That was TNC?
I don't know. Who it was.
All right.
Oh.
I know.
Don't pressure. Pressure.
I do have 30 minutes. I may take 45. I might. You might be stuck with me for 45 more minutes.
Terrible.
Are you going to be able to stand it? So, you guys miss me. I know you do. Danae? Where's Danae? I don't know. Yeah, it's usually. And Trey works. So he told me he wouldn't even be here till 2. And
Puppy said that today. You could have canceled work for this. I canceled work.
well, he told me that last week. He couldn't be here at 2, and I said, well, I would only be here at done about 2:30, 2:45, and I couldn't. They are mad at Trey. They are really mad at Trey.
Looks like.
If he wanted to, he would. Exactly. That's what I'm saying.
Yeah. Okay, so your first gold one is ALS. Well, it's not your first gold one, but on your sheet it is. Page, I'm sorry. 294, actually. Go to 294.
I'm looking at the wrong thing.
It's literally 294 and 295.
Our gold section.
You're in your gold section. Okay, so it's a demyelinating disease, right? They pretty much are going to lose motor control completely. Okay? It's in the premotor area, it's in the sensory cortex, and it's in the temporal cortex. And they all cause symptoms of ALS, along with demyelination. Degenerative disease, chronic degenerative disease, is there a cure for it? No, there is no cure for it. Okay? What, when I talked to you guys, was one of the big controversies about exercise? You don't want to overexert, but about exercise and ALS. Big controversy. It speeds up the disease. It speeds up the progression of the disease. Okay? And so if we are actually going to exercise them, what is a criteria for how we choose which muscles to exercise or which muscle actions to exercise? Anybody remember that?
Like the low impact exercise?
Nope. The criteria to say, okay, I'm okay to go ahead and exercise quadriceps. How do I know that? Nope. So they become weak. If they're weak, they're weak. So, okay, nobody remembers. So it's with a manual muscle test. So they have to have at least a 3 or above. Okay? So you're only going to exercise because it's not going to help the other ones. Okay? A manual muscle test of 3 or greater. Greater. Is this greater than? Greater than. Yes. Greater than 3. Okay? So those are going to be the only ones. And there were phases that you went through with ALS. Do you guys remember that? So in the beginning exercises, you can do exercise. But by the end, what are you doing by the end? The end stage. Not really. Who said pressure? Pressure what? Pressure relief by positioning. Yes. Pressure relief. Assistive devices. Family education, right? It's a progressive disease. Family education. Okay. So this here is the big precaution on exercise. Okay? Because you do not want it to speed up the regression. right? Okay. So you're probably going to have to do some kind of home modifications, wouldn't you? And I'm talking about home modifications that they might need a Hoyer lift. They might need a hospital bed. They might need outside assistance. Okay. They may need a wheelchair, but they're pretty much bedbound by the end. If they had money, they could have those air mattresses, that kind of stuff, if they had money. Saddest thing I ever saw was a couple came in. This guy came in, and they usually tell this story in class. And he, really nice guy. And he was having weakness and stuff, and we exercised him. We didn't realize, then he got diagnosed with ALS right after that. But he pretty much had 3 or greater prior to that. But then he was diagnosed with ALS. And he came back in, and we were like, kind of contraindicated for us to keep exercising you. But he's like, no, I want to keep going. But the saddest part about it was, so him and his significant other at that point, it was his significant other, and they'd been together for years. So he ended up marrying her, because he wanted to make sure that she got access to everything that he had. And if he didn't marry her, she wouldn't have gotten anything. Yeah. So it was really kind of like a bittersweet love story kind of deal. Falls is a big one with these two, right? Falls risk. Guys, remember anything else about ALS? Looking in your book, can you see anything else?
Decreased aerobic capacity.
Oh, yes, thank you. At tolerance, probably. Anything else? Well, muscle atrophy, cramping, all that kind of stuff. Distal to proximal. Remember, that was a big thing. Okay, so muscle atrophy is distal to proximal. I kind of already went through treatment with those, didn't I? Gave you a whole bunch of stuff on treatment and management and all that kind of stuff. Drugs are involved in it to manage it, not for any other reason. Okay. We talked about home adaptations. It is fatal. It's Lou Gehrig's disease. ALS is Lou Gehrig's disease, if anybody remembers that. Oh, eating becomes a huge problem. So they have problems with dysphagia. Okay. Dysarthria. Do you remember what dysarthria is? Yeah. Issues with speaking. Okay. So all of that stuff happens. All right. You're just going to have to study these. So I put them in here to make your life easy. Okay? So that you can look at them rather than, oh my God, look at all these words in pure sentences. Okay? Make sense? Helpful? Okay. So let's flip on the next page on the back of it, Alzheimer's. Alzheimer's. I find it interesting that they are literally doing Alzheimer's as a primary pathology on the test. I think that's really interesting. Because, first of all, truly Alzheimer's cannot be diagnosed until after post-mortem. But you would treat dementia very similar to Alzheimer's, wouldn't you? So instead of calling it dementia, they're calling it Alzheimer's. Alzheimer's is on page 292. Yep.
I really got more about like Down syndrome.
We're going to get into that. That's in here too. Down.
I don't know if there's Alzheimer's.
What? Okay.
Maybe about sundown.
Yes. So that's your signs and symptoms of it. So sundowners, does anybody know what sundowners is? Yep. Yep. So it's a dementia, short-term memory loss, right? They can remember. They think it's caused by plaques in the brain. So they can remember a long, long time ago, but they can't remember what they did 5 minutes ago. My best friend, her mom just passed away last week. It was kind of a blessing. She had early onset Alzheimer's, and she was she went from an ALF to where she was now in a memory care unit. And she lives in the same area of South Carolina as my girlfriend does, and she's the primary caretaker of her, everything else. And her brother lives in Maryland. And when her brother came to visit her, he hadn't seen her for months. She didn't remember who she was. So you've got to know this guy to find this like super, super funny. But he was like, yeah, I just need to let you know that your son, he's saying this to his mom, is doing really, really well. Yes, he's made it really far. He is president of the United States now.
Wow.
And that's what he told and she's like, oh, wow, that's great. Like, she doesn't even know who the president of the United States is. But all we could picture after that was that she went around and said to like her friends there, my son's president of the United States, you know? Of course, she didn't remember any of it, but. And if you know, yeah, and if you know it, like it's even funnier knowing this guy because he's just like he tells you that kind of stuff. You know, I've known him for 30 some years, so I'm like, yeah, Trip, I don't believe you at all. All right, so sundowners, short-term memory loss. So what happens with all of this? Is it just your short-term memories that you don't remember who people are, or what else do you lose? Yeah, poor judgment, because they don't realize that they have these issues. Are we going to have balance issues? Are we going to have falls risks? Yeah, she fell multiple times before she died. Are we going to have muscle atrophy? Not probably due to the disease, but secondary complication, right? Are we going to have gait disturbances? Yep, shuffle gait. They don't want to pick up their feet. So they have transfer difficulties. So when you're looking at these pathologies, try to visualize what you would see with that particular patient. Can't you see all this stuff on the Alzheimer's patient? Yeah. So when you see all these things, then you're going to be like, what am I going to work on? Isn't that easy? To figure out how you would work on them, what you could possibly do with this patient. Okay? You know there's a falls risk, so you're always going to be very careful with them. They might need, they usually don't alarm them. Like they usually don't alarm their chairs or things in, even in memory care. Like they don't. I don't know why. But a lot of times the patients are afraid of falling as well. So that might be why. They don't want to stand up. They don't want to move around. They actually don't remember eventually how to stand up. They don't remember how to walk. They don't remember. There ends up being swallowing issues because they don't remember how to feed themselves. Yeah. Incontinence because, yes, they forgot when they had that urge that they needed to go. Okay.
You need to know the differences between each incontinence. That is very important.
I mean, bladder and bowel?
No,
Like
all
stress.
types. Yes. Yes. They will always ask.
Stress,
There's 4.
urge, incontinence. Yeah, there's, what's the bladder one?
Come on, Miss Lisa.
No,
There's 4 of them.
there's the just this bladder, reflexive bladder or something like that. Isn't it where they can't go? That's one of them. What's the other two?
I only know stress and urge.
I know those for sure.
Yeah, they're big on that.
That's ridiculous that they are.
I want to know if we're nurses too.
I guess because pelvic health is getting more.
Yeah, because pelvic health is getting more popular. No. Isn't that what it would be? Stress? Stress? Yeah, but stress happens with pregnancy.
Yes.
Yeah.
It's stress, urge, overflow, mix, and function.
Wow. See, I never even learned those.
It's just like one question.
Yeah,
Like what would happen if you sneeze? What?
But they're going to give you
Stress.
all of those, and you want to know which ones it is and which ones it's not. So that's important.
Okay.
Did you find the page or you just listened?
I looked at that because I couldn't find it.
That is something I did not know. Did not know that.
Should be in your book though. Your school builders. It's not looking.
Probably the other systems.
Yeah, that's going to be way on other systems. I am not teaching you those.
No, I just wanted to say that as a statement that it reminded me.
Okay. Yeah, I am not. I am.
What page is
Oh.
that?
484.
Is it all of those, or did they leave out mix?
Urinary stress, urge, overflow, functional, urinary tract.
What's functional?
Functional urinary incontinence.
Mm-hmm.
It's the loss of urine due to the inability of unwillingness of a person to use the bathroom facilities prior to involuntary bladder release.
Alzheimer's disease.
Yes.
They're functional. Okay.
Functional incontinence.
Yeah. Functional urinary and probably bowel incontinence too, I'm sure. They don't even think about that. Okay. So there are certain medications that they can go ahead and use with it now. There never used to be, but once Ronald Reagan came down with it, there got to be a lot more research. And so they've come up with different medications for it. I don't think they're going to ask you about the medications for Alzheimer's because we're not really involved in that so much. Okay. So what do you think we're going to focus on when we do this? What are we going to work on? Huh? Retraining, like trying to use what they've got, right? So it could be some gait training. It could be some balance training. Are they going to remember how to do all this? No. Transfer training. What about strengthening? Because they're not moving around as much. Strength and endurance. Okay. On this kind of stuff, you're kind of hoping that muscle memory will take over. But I did a research project on Alzheimer's and memory, and it's like 200 or 578,000 repetitions before it sets in. Yeah. You could do blocked because they don't have the endurance, so you probably would end up doing blocked. Okay, but you're not going to do random. Yeah, you're not going to do random practice. Okay. Safety is going to be a big thing. So you want to do like So you don't want to change their environment a lot because they don't recognize it. So if they are at home, the only way you would change it is if you had to adapt it for them to get by with a wheelchair. All right. But if you decide that you are going to go ahead and tell the person, the caregiver, to go ahead and rearrange the room because you think it's going to look better that way and be safer for the patient, they're not going to recognize the room any longer. Okay. So you don't want to do that. But you may have to get a shower chair because their endurance is down. Okay. They may not even use the shower chair in the shower. It may be sponge bath for the caregiver. God bless you. Okay. A lot of times, if you give them walkers, they don't remember to use the walkers. We used to, with all our dementia and Alzheimer patients, we used to put like wrap big pink tape around it so that they would at least notice it, that it was there. But I remember going into people's houses and be like, okay, here, let's use your walker. And I'd place it in front of them and they'd go, okay, and then walk. Like they used it, right? They used it to move it out of their way. All right. But they can't find that kind of stuff. They can't remember those things. They do a little bit of like hallucinations. So like if they can't find where this is really pretty common. It happened with my girlfriend and it happened with my mom. Like she's like, I can't find my earrings. I can't find my pearl earrings. The maid or the assistant must have gone ahead and stolen them. They don't think that they placed them somewhere they can't find it and they don't remember it. They think that somebody else did that to them. So they'll do that all the time. Okay. So you don't want to change their routine. You want the routines to be pretty standard. Okay. My parents moved to Florida when my mom started to really get affected by her Alzheimer's, and she kept wanting to go home. She didn't understand. It was safer for her where she was at and she got more mobile, but she just kept wanting to go home. Now, to keep her moving was great because Florida didn't have snow and ice like Connecticut did. So for 365 days a year, she could pretty much go outside and walk and keep her endurance up and gait training and all those other kind of stuff. While for months up north, she was kind of immobile and it really caused a lot of problems. So it was much better to do that kind of change. No, she was gone before I moved down here. She died when I was like 32 or something like that. I was really young when she died. You may not think that's young, but I was. Okay, so you're going to like assistive devices, adaptive devices for the caregivers, caregiver training. Okay, we're not going to make it through all these, but that kind of stuff. See where we're going with this? Okay, so does that help you guys on those kind of things? Oh my God, I got 8 minutes. Let's try to do one more. Epilepsy, the biggest thing on epilepsy. We already talked about that a little bit, didn't we? The safety things. Okay, what to do. We're not going to stop them. And we're going to stick a tongue depressor in their mouth so they don't chew on their tongue, right? No, we don't do that anymore. No.
Running it, and then I was like, wait, what?
Right. So Stephen's like, and Andrew's like,
I'm doing this, but
yeah. So no, you definitely are not going to be doing that. Okay. So carpal tunnel syndrome, is that a peripheral or is that before I go through that, why don't you guys just tell me which ones you want me to go over based on looking on this list since we have such a short period of time left. Or do you guys pretty much get an idea of what you can? Guillain-Barré?
Yeah, the one I can't say. Looked at it a little bit.
Okay. We went over CVA a lot. Guillain-Barré. heck is Guillain-Barré? I always get Guillain-Barré confused with myasthenia gravis. So make sure you don't. Those two are kind of close. 306? Skipped right by it. Okay, so it's another demyelinating disease. Okay, so it eats away at the myelin sheaths. So when it eats away at the myelin sheaths, what is that? What does that do to motor function? Huh? Not good. Not good, Hal. You guys are all so tired and wiped out. Decreases, weakness, decreased speed, like MS. Doesn't MS do the same thing? It's a demyelinating. So remember that you have the myelin sheaths, and then they have the roads, the nodes of Ranvier, and so they jump from one to the other. But if it's, and that speeds up the electrical conduction to make your muscles contract. But then if it's demyelinated, it's going to really slow it down. So your pain fibers are not myelinated, all right? Or are they myelinated? Something's not myelinated. I don't know. It's the end of the day and I can't remember anymore. Some of them are and some of them aren't. Okay, it depends on, there's those different nerves. Did they ask a lot of questions about the beta, the alpha nerve, the this, the that, the next thing? Thank God. I don't understand why they would. If they're trying to make this much more treatment-based, like you kind of have to know that stuff, but I don't know why they would ask you it because you're not really going to deal with it when you're out there. Yes, exactly.
So this one's distal to proximal too.
Distal, yep, distal to proximal. Okay. Where are we? What are we doing? Guillain-Barré. Distal to proximal weakness, right?
Yeah.
Okay. Okay. So that's one of the first things that you will go ahead and see with that. It is an autoimmune disease. So your body is attacking it, attacking itself. Okay. It's an autoimmune disorder. All right.
This is corticosteroids are controversial and usually contraindicated.
Why? Okay. Honestly, don't know why. Huh?
Don't they weaken and cause degeneration?
They can, yeah. Yeah, they can. With nerves? I thought they did it more with tendons and that kind of stuff. Corticosteroids weaken and cause degeneration of tendons. Yeah, osteoarthritis, and they can do the tendons. So that's probably why. Okay. I know it does the tendons and stuff. One of the antibiotics I was on did the same thing. I can't remember. It was one of the antibiotics we talked about in pharmacology that'll actually do tendon rupture. We did that little case study about the runner who started to have pain with corticosteroids because there was a particular thing they put me on with that was involved with that. And I was like, oh, crap. That really worried me. Okay. All right. They're not going to really, you're going to see where the presentation is and stuff. Muscle and respiratory paralysis. Why would you have respiratory paralysis? Thank you. The diaphragm, which is innervated by the pharyngeal nerve. Okay. You would definitely have that. Yeah. They diagnose it by doing a spinal tap. They take a sample of your spinal fluid. Okay. So, treating it. How are we going to treat this? We can't really fix it. No, we can't. Okay. Can we work on what they've got left? Yes. So we can work on strengthening, okay, with what's there. We can do some endurance with what's there. Okay? Yeah, we can work on some transfer training, balance, gait. They might have to have assistive devices to help them through. Caregiver training. That all makes sense, doesn't it? Okay.
says you can use a pool therapy.
Pool therapy would probably be a really good one for this. Would pool therapy be good for Alzheimer's?
No.
Thank you. No. They might drown themselves.
Best case scenario, they crap.
Huh?
The best case scenario, they crap the pool.
Crap in the pool?
Yeah, they get you out.
Best case scenario.
Yeah, worst case scenario, they drown.
Oh, the best case scenario. Okay, I'm following you now. Any other ones you guys want to go over? That's about,
That's my main one.
because you're all fried. But do you understand what the thought processes were on these? Has this been beneficial?
Yes.
Beneficial, guys?
For sure.
Better than the last year's and the year before? Okay. Good. What'd you say? What did you say?
Nothing about you.
Okay. All right. Any questions? Took me a minute. I am tired, but I understood now. No questions? All right. So I am going to end up turning you. Guys want to take like a 5-minute break, stretch your legs. I'm going to turn you back over to Miss Denise. I know she's got some announcements. Then you've got Shane coming, who's going to be talking to you guys at 3:30. Okay, which is pretty exciting. And
So exciting.
yeah, yep. So if you have questions, you can always ask me. Your brown squid.
Penetration of the chair. Yeah.
Only you. Yes. Only you. Penetration.
I gotta put down the survey. Literature.
Yeah. Oh, you should have seen the chairs that we had before. These are a huge improvement from what was at the other building. They had no backs to them. The other chairs. These are definitely more comfortable than the other ones. And besides, if you're in a clinic, what are you going to use?
Well, when you're in a 4-hour lecture.
No, sorry. I give you breaks.